Laboratory diagnosis of tuberculosis. Myself, Dr. BT. Tuberculosis or TB. It is a common and often deadly infection caused by Mycobacterium, usually of the species Mycobacterium tuberculosis. The genus Mycobacteria is divided into Mycobacterium tuberculosis complex and NTM, which is non-tuberculosis Mycobacteria. Mycobacterium tuberculosis complex consists of Mycobacterium tuberculosis, Mycobacterium bovis, Mycobacterium bovis BCG, and Mycobacterium africanum. So let's talk about the pathogenesis. So the inhaled aerosols, when engulfed by the alveolar macrophages, the bacilli replicate and kill the macrophages. So the infection macrophages mitigate or migrate to the lymph nodes. This area is called the Ghon's focus, which is known in the primary complex. So the cell-mediated immune response here stops the cycle of destruction and the spread. So here the bacteria is viable but not replicable or replicating inside the macrophages. So here what happens? The chest X-ray and there is positive tuberculin test, which is the evidence of infection in Mycobacterium tuberculosis in this condition. So Mycobacterium tuberculosis affects most of our body. You can say except the hair and nail, every part of the body is infected. So now comes the sample collection. In pulmonary condition, you can collect the sample gastric lavage, transtracheal aspirate, bronchoscopy, and laryngeal rubbing. For extrapulmonary, you can choose urine samples, tissue bed, body fluids, and blood specimen, wounds, and aspirates. So the sample collection depends upon the area of sputum collection. Sputum collection in the morning before any meal should be done. There should be no oral antiseptics used. 2 sputum samples are required. If sputum is not available, you can use laryngeal swabs, bronchial washing, and in small children, gastro lavage can be used. So what do you see in the sample of sputum? So first the sputum should appear mucoid or even blood stained. They contain many WBCs. So saliva, you can see it is clear, watery and frothy. It contains many squamous epithelial cells, and WBCs are absent in this condition. So in laparoscopy, you start with microscopy, culture, animal inoculation, nucleic acid technology, and allergic. So sputum is stained by Zn stain. So you have to collect 2 morning stain samples which are mucopurulent. So the advantage of this test is it is cheap, rapid, and easy to perform. The disadvantage is the sputum should contain around 5,000 to 10,000 bacilli per ml. So young children, elderly people, and HIV infected people will not produce cavities and the sputum containing AFP. Limitations of microscopy in tuberculosis. So repeated sample examination is required, load of technical staffs, training and dedication of microscopists. The load of bacilli must be more than 10,000 per ml of sputum, so low sensitivity is less than 50%. Repeated requests for samples, high dropout by patients for repeated sample, and not dependable in pediatric age groups. So this is how your AFB stain will look like. So what is sputum positivity? So all the patients who submitted 2 samples and found to be specific for identification of AFP are considered to be positive for sputum microscopy by WHO. So this is a grading. You should be very thorough with this. I'll give you a minute, just go through. So if you have more than 10 AFP per oil immersion field, you have to grade it as positive, and according to grading it is 3+, and you should examine around 20 fields. This is a RNT-CP grading. Okay, so if you have 1 to 10 bacilli per oil immersion field, result is positive and graded as 2+. 50 fields should be examined. For 10 to 99 AFP per 100 oil immersion field, it is positive. It should be graded 1+, and around 100 fields should be seen. And if you have 1 to 9 AFP per 100 oil immersion microscope, it should be graded as scanty. Result is positive and 100 fields should be examined. Okay, so here if you determine the patient is having scanty AFP, you should actually record the number of bacilli seen in 100 fields. Okay, you should count it. And if no AFP is seen in 100 oil immersion field, it is negative. Second, by using fluorescence microscopy. So the smear may be stained with ornament over dye. In this method, TB basically is stained yellow against dark background and easily visualized using fluorescent microscope. So advantages are it is more sensitive and rapid. Disadvantages, it is having toxicity. The dye which we use, right, the ornament, it is toxic drug. It is more expensive and it should be confirmed by Zn stain. So anyway, you have to confirm it using Zn stain even if you stain using fluorescent microscope. So this is a picture depicting the fluorescent microscope. So the yellow color curved structures are the bacilli. Understood? So why do we need a fluorescent microscope? It is useful when a flu bacteria is present, increases sensitivity in HIV patients with tuberculosis, reduces the time of testing. Around 15 times more fields can be seen using fluorescent microscopy. Then the sensitivity is increased by 10%. Better conclusion with 1 or 2 specimens, unlike seed stain, is required. So in seed method, you require 3 or more samples. Here 1 or 2 samples are mostly sufficient. Processing direct spheres. So sputum microscopy can be inverted with sputum liquefaction, concentration, and gravity sedimentation. So the popular solvents which we use are sodium hypochlorite and sodium hydroxide and ammonium sulfate. And one more thing is NaCl, N-acetyl cysteine. Okay. So culturing. So here we use culture method for identification of mycobacterium species. This is considered to be a golden standard method in developing countries. To obtain by colonies in culture, you require only 100 bacilli, around 10 to 100 bacilli is more than sufficient. In staining, you require 10,000 bacilli per 1 ml. Understood? So this is also a golden standard of identifying mycobacterium. So recent facts in culturing, it is used in HIV patients. So if a few bacilli are present, it can grow, but the specimen need to be incubated for a longer time, around 8 weeks, as few bacilli. So what are the media which we require? So agar-based media are Middlebrooks media, which is Middlebrooks 7H10 and Middlebrooks 7H11 and Middlebrooks biplate. So egg-based media are LJ media with pyruvic acid and LJ media with iron. So culture is inoculated at 35 degrees Celsius in the dark in an atmosphere of 5 to 10% of carbon dioxide and high humidity. Cultures are examined weekly for growth. Most isolates appear around 3 to 6 weeks of growth, and some may even grow around 7 to 8 weeks. So after 8 weeks of incubation, as I told you, you can report the sample as negative if no growth. So how the colony of Mycobacterium tuberculosis will look like? So they are rough, tough, raised, irregular colonies with a wrinkled surface. They are creamy white and become yellowish and buff colored on incubation. So this is the rough, buff and tough colonies of Mycobacterium tuberculosis on an LJ media. So the commonly used liquid culture media are Bactec 460 and the Bactialert 3D. Okay, Mycobacterium tuberculosis can be also cultured in Mycobacterium growth indicator tube like MGIT. Bactec MGIT 960 can be used, and here the continuous growth can be monitored. Liquid media. Use of liquid media can reduce the turnaround time of isolation of acid fast bacilli for around 10 days when compared to 70 days or longer in conventional technique. Once the growth is detected in liquid media, the acid fast bacilli stain is performed and confirmed. Recent method of diagnosis, Bactec 460. So here the specimen culture in liquid media like Middlebrooks 7H9 broth containing carbon 14 labeled palmitic acid. Okay. So here the mycobacteria utilizes the acid and releasing radioactive carbon dioxide, which is measured as a growth indicator. So the daily increase of GI, that is the growth index output, is directly proportional to the rate of growth in the medium. So the advantages are it is rapid and determine the drug susceptibility. Specificity is very high. Okay. So you can detect Mycobacterium tuberculosis in around 10 days using this method. So disadvantages are it is expensive and it uses radioactive material. So these are the. Next is Mycobacterium growth indicator tube. So this tube is a modified Middlebrooks 7H9 media broth with OADC enrichment and Panta antibiotic are used. All types of clinical samples like pulmonary as well as extrapulmonary except blood, which is an inhibitor, can be used in this media. Principle of procedure. So a fluorescent compound microscope is embedded in a silicon bottom of the tube. The actively respiring microorganism consumes oxygen and allow fluorescence to be observed using a UV illumination light. The MG960 system. The MG960 system is a non-radiometric automated system that uses MG80 media and sensors to detect the fluorescence. The advantages are that this system holds 960 plastic tubes continuously monitored. So early detection of the machine monitoring and reading the tubes every hour helps in early identification. Approach. So growth on solid media or liquid media and perform the acid fasting. Several colonies of solid media are inoculated in middle rules media in around 5 ml and it is incubated for the 5 to 7 days at 35 degrees Celsius and daily agitation is required. So either the broth or the growth in the primary culture media are inoculated in a test media containing biochemical tests and pigmentation are determined. So here you grow this broth in the primary liquid media and the inoculation should be done. Okay, then biochemical test has to be performed and pigmentation has to be observed. This is the meaning of this paragraph. So what are the biochemical tests which can be done? So first thing is niacin test, second is aryl sulfate test, the catalyzed peroxidase test and nitrate detection test. So niacin test is specific for human mycobacterium tuberculosis and aryl sulfate test is positive in conditions where atypical mycobacteria grows. Catalyzed peroxidase test is used to differentiate between typical and atypical mycobacteria. Nitrate detection test is used for identification of mycobacterium tuberculosis and Mycobacterium bovis. So here nitrate detection test is positive in Mycobacterium tuberculosis and negative in Mycobacterium bovis. Next is nucleic acid probes. So nucleic acid probes are commercially available for these many organisms. For example, Mycobacterium tuberculosis complex, AVM complex, Mycobacterium AVM, intercellular, Kankasi and Gorday. Next is chromatographic analysis. So analysis of mycobacterium lipids by chromatographic methods like using gas liquid chromatography and reverse phase high performance liquid chromatography. Polymerase chain reaction and gene probe. Nucleic acid probes and gene acid probes amplification in which polymerase chain reactions are done. Okay, so here you make multiple copies of specific DNA or RNA sequences extracted from the microbial or that is mycobacterial cell. Okay, so the advantages are this: it is rapid and it has high sensitivity. So how rapid? You can get the results in around 3 to 4 hours and around 1 to 10 bacilli per ml is easily rated. So this is a PCR procedure. Just go through. So next, disadvantages of PCR: very expensive, requires specialist training and equipment, false positive results may happen. Okay, so here you can differentiate between dead and live bacteria. So next is emerging rapid methods. First is the fast plaque TB phage, ELISA, which is also called as quantiferon TB gold. Enzyme linked immunoassay like ELISpot. So ELISpot has been proved useful and detecting tuberculosis in in adults and children. IV fast plaque TB test. Patient's sputum is mixed with mycobacteriophage. A virulence is a viruside is added, which destroys any phage outside the TB bacilli. Lysis of the cell and release of the phages after replication within the tubercular bacteria is done. No pathogenic mycobacterium are added in the sample incorporated in agar mixture. Zones of clearing indicate that the patient's sputum contains viable mycobacterium tuberculosis. So this is a pictorial representation. So next is interferon gamma test. This is a in vitro T cell based assay test used to diagnose latent tuberculosis infection. It is also called as quantiferon TB gold test or T-spot test. So these full blood assay measures interferon gamma production by previously sensitizing lymphocytes in response to mycobacterium tuberculosis specific protein antigen like ESAT6 and CFP10. So evaluation of different methods of diagnosis as regarded with time. The MG80 has shortened mean to determine the positivity at around 13.3 days compared to 14.4 days in Bactec 460 system and 25.6 days in LJ medium. So the best yield with Bactec 460 is followed by Bactec MG80 960 and LJ medium. As regards with contamination rate, LJ medium has 17% contamination rate, which is highest among all the methods. So methods used to determine the susceptibility of Mycobacterium tuberculosis to antibacterial drugs. First is an absolute concentration method. Here resistance is expressed as lowest concentration of the drug that inhibit all or at most all growth, that is a minimum inhibitory concentration. So antibiotic susceptibility testing, you can also do the resistance ratio. So it is expressed the ratio of MAC of the test strain divided by MAC of the standard strain for every drug. Next is proportion. The extent of growth in the absence or presence of the drug compared and expressed as percentage. If growth at the critical concentration of the drug is more than 1%, the isolated is considered to be not sensitive, that is resistant. Okay. Radiometric. The rate and amount of carbon dioxide produced by the absence of the drug or in the presence of the drug is compared. So the newer methods are line probe assay for repeat mutation, high density DNA probes, luciferase gene. So next is non-specific test. Example, tuberculin test. Montaux. So the test can be interpreted in the relationship between the clinical evaluation. Even if the intervention is 5 mm, it is to be considered positive when tested in HIV patients. This one lacks specificity. The Montauk test, what you do is you take 0.1 ml of PPD containing 5 tuberculin units is injected intradermally on the flexor aspect of the forearm. So it is examined around 40 to 72 hours. The duration is around 10 mm in size, which is considered to be positive, and if it is less than 5 mm, it is considered to be negative. Second test is the multiple heave test. Third is the disposable prongs carrying dried PPD test, which become positive in 4 to 6 weeks after infection and immunization. Next is allergy wanes gradually and disappears after 4 to 5 years. Uses. It is used in diagnosis of infants and in young children, measure the prevalence of the infection and select the susceptibilities. Dealing with HIV and tuberculosis infected patients. So diagnosing tuberculosis in HIV infected patient is a priority and improve the quality of life. So here you have to consider the HIV status, identify the severity of the tuberculosis, early use of chest radiography, maximal number of sputum samples should be collected, sputum concentration method should be encouraged even if the smaller laboratories. Explore the use of fluorescent microscopy, all smear negative samples should be collected. Extrapulmonary tuberculosis poses several challenges yet not optimal specific diagnostic. So what does it do? It is a real challenge for clinical people and the laboratories. Optimal specimen collection is a priority. Molecular methods are growing need. Clinicians should start drug regimens on empirical basis. Several serological tests for antibody determination are identification of atypical bacteria. A growing concern in infection which is less common, uncommon mycobacterium in immunosuppressed and emerging infectious disease. So here you have to need the help of reference laboratories. You have to take different drug regimes unlike typical mycobacterium isolates. So now a growing concern in the era of AIDS is atypical mycobacterium. So you have to consider this as a next differential diagnosis whenever required. So future perspectives. This is a highly essential to explore the discovery, rapid, simple and accurate tuberculosis diagnostic tools. A massive investment, greater scientific interest, political commitment to be a top priority. Manpower development, human resource utilization, a greater concern. Microscopy and fluorescent microscopy technique should be immediate concern and strengthening the treatment initiation protocol should be done. Effective methods in diagnosing smears negative patient is priority. So, in spite of several scientific and molecular advances, microscopy in tuberculosis continues to be the backbone in diagnosis. And this comes to the end of the lecture. Thank you so much. Keep supporting. Thank you. Take care.